equivalent to a doctor's visit, that would be awesome. So let's get to it. Okay, today we're talking about plantar fasciitis. This is probably the most common thing a foot doctor treats. In my office, it's like the common cold for a primary care doctor. See it all the day, see it every day, all day long. When I was in medical school, I wrote a paper on this, a review paper, going through all the research at the time, trying to decide what the best treatment options were, see if there was any silver bullets we were missing. I had noticed that my attendings were treating it all the time in clinic, and I thought I need to understand it better. So the really disappointing outcome of that paper was there was no silver bullet. Every study worked 60 to 80% of the time. Those that claimed to work higher than that seemed to have a bunch of flaws, and in reality didn't seem to pan out. So what I have found over the last few years in practice is that it takes a village. It takes a lot of different modalities to get this thing to go away, and it takes time. You have to be very patient with it. So if you're looking for a quick fix, this is not the place, mainly because it doesn't exist. There are people who will say, well, I did this and my pain went away, but that doesn't usually pan out for everyone. But I'll tell you my experience. We'll go through all the different modality options. So plantar fasciitis, it's very straightforward in most cases. What it is, if you look at the bottom of your foot, right at the heel bone, right underneath the heel bone, there's a band of tissue. It's a big, thick, ligament-like tissue. It's a fascial band, and it's like a big rivet, and it goes from the heel, right at the heel bone, all the way out, and it spreads out into the toes. There's a medial band right on the side, and then there's a little lateral band that comes over to the other side of your foot. If you look at a skeletal model, the bottom of the heel actually has two big lumps here, and those are the attachment points for the big medial band of the plantar fascia and the lateral band. And again, they spread out and go out through the arch of the foot, hit the base of the toes, and then peter out into the other connective tissues. I like to call it a string on a bow. It crosses that arch, and it's really tight. It helps hold the arch up. It's a structural thing. If you pull the toes up, it actually pulls that plantar fascia very tight, and you can feel it right on the bottom of your foot underneath the skin. So diagnosing plantar fasciitis is usually pretty straightforward. You can pull the toes back. You pull the toes back on a patient that you can feel that tight bowstringing band of tissue. You push along it, and almost inevitably somewhere in the middle or right at the insertion point on the bone, they jump out of the chair and say, that's the spot. The usual story is that the pain is there in the morning. As soon as they start walking, it hurts like crazy first thing out of bed, but it usually warms up and goes away. Throughout the day, if they're on their feet a lot, the pain can come back, especially if they're on it a lot, but eventually, once they're sitting down and resting at night, the pain goes away again. That's a typical story. The more advanced the plantar fasciitis becomes, the longer it hurts throughout the day, and it can get to the point where it hurts all day long, no matter what you're doing. But that's the typical story. Most people don't have a story that describes when it began. It just shows up one day and it starts to hurt. But if you dissect a patient's story far enough, you do start to discover that something did happen. Just now, I was just talking to a patient who said that school had started. She's a teacher, and that she's on her feet a lot more than she normally would be, so the pain started up again. She'd had it on and off for years. Classic story. Every summer, early summer, I get a whole bunch of patients in who had a New Year's resolution to run more, to walk more, and after a few weeks or a few months of that, and doing it incorrectly or starting too fast or having bad shoes or no orthotics or something was going on where the pain started, they kind of tried to plow through it for a few weeks and it got too much or they had to stop. So that's usually the story. Usually it's not a fall, it's not usually trauma, but it can be. Some people will fall on their heel, partially rupture the plantar fascia, or even just tear it at the very micro level, and it takes forever to heal, and pretty soon they went from an acute injury to a chronic injury. But in the end, you end up with this plantar fascial band through the bottom of the foot that is now inflamed. The inflammation is hard to get rid of. Every step you take, for most people, they strike the heel first, right where that plantar fascia is attaching on the bone, and then they push off, and as like I mentioned before, when you push those toes up, the plantar fascia tightens. So when they push off, everything gets really tight and it stretches it. So you get an impact and an indirect stretching motion, and the plantar fascia never gets a chance. Every step you take sets you back a little bit, and it's very hard for the tissues to heal when they're pounded like that. Sometimes I envy the hand surgeons because they can put their problems in a sling and rest it. In my world, it's where the rubber hits the road, and it can be very hard to heal. So that's the diagnosis. You can get x-rays. X-rays are useful. I'll show you one now. On the x-ray, you'll see a spur sometimes not. One of the biggest misconceptions about plantar fasciitis, it used to be called heel spur syndrome or something similar to that. One of the big misconceptions is that if you have a heel spur, that's your problem. And the truth is very rarely is it the problem. The heel spur will form because the plantar fascia inserts right on the bone and it pulls so hard right there. Combining that with chronic inflammation, the bone gets irritated, it starts to create more bone, and you get this spur that forms out from that area. That isn't what hurts usually. If you get an MRI, almost every one of the MRIs shows that the inflammation is in the soft tissue, the plantar fascia, and not the bone. Now, of course, there's exceptions to that. Sometimes the spur gets really long, you break the tip off. Sometimes the spur is what's inflamed, but more often than not, people come in, I take x-rays for other completely unrelated problems, and they have a heel spur. Never heard of, never did, and hasn't yet. So you can't say that because you have a spur, that's your problem. It's a sign of stress on the bone for sure, but keep in mind that heel spurs take a long time to form. We're talking years and years. So your plantar fasciitis story may only be a few months old, and the spur's been there for years, so you can't really say that's your complete problem. So anyway, you can get an x-ray. On the x-ray, if you get a really good one, you can see how thick the plantar fascia is, but it's not the best way to determine how thick it is. The average person who has a healthy plantar fascia, it should be between 2 millimeters, 3 millimeters thick, and you'll see some that are 5, 6, 7, 8 millimeters thick, meaning it's been inflamed for a long time. Now you've got scar tissue forming, and you go from plantar fasciitis to fasciosis, which means the tissues themselves are now damaged and thickened and scarred. You'll even get little fatty infiltrates in there if things are really bad. Ultrasound can be better at measuring the thickness of the plantar fascia. Ultrasound shows soft tissue much better. If you have a high-end one, you can easily see the plantar fascia. I'll show you some images of that. It's very easy to show the thickness. It's a little harder to see the interface between the bone and the soft tissue, but it can be useful. MRI is really useful. If it wasn't for the fact that they often cost $500 to $1,000 or more, I would get an MRI on everyone just to see all the information I need. On MRI, you can see bone, you can see soft tissue, and you can see inflammation, which is important because the tissue that's inflamed is usually the problematic tissue. So if I had a cheap MRI machine in my office, I'd do it all the time. I don't, and usually it's overkill to get an MRI right off the bat, unless everything's failing to work, but it is good information to really nail down where the inflammation is and where the problem is. So let's say we've determined you've got plantar fasciitis. Imaging shows you've got an inflamed plantar fascia or a thickened fascia. Your story kind of lines up with soft tissue injury. We've ruled out the crazy stuff like bone tumors and other problems inside the calcaneus, the heel bone. So now we're ready to treat the plantar fascia. Let's start from the ground up, and I'm going to go from the most conservative treatments to the most invasive. The first thing, number one, has to be on your list is the shoes. You can't wear flip-flops. You can't go around barefoot. You can't wear flimsy, silly little shoes, flats, ballet slippers, or whatever, and expect the plantar fascia to get better. You need a really stiff shoe. So I've said this before, but the shoe itself, it can bend at the toes, that's fine, but from here back, that thing needs to be really, really strong as you can handle it. I don't care if you're a runner, a walker, golfer, whatever it is, the shoe has got to be strong. I cannot tell you how many people I've finally convinced to replace their shoes. Once they get rid of the flimsy, terrible shoes and they get into a stiff one, they say, you know what, a lot of my pain went away. So if people would do that, they'd probably save themselves a lot of money at the doctor's office by just replacing their foot. Their foot would be nice, their shoe, and go for something very stiff and solid. My favorite brands are New Balance. Just make sure the shoe itself is stiff. Some of the models aren't great. Hoka's have some really great ones. Ultras have some great ones. Trying to think what else. Dress shoes are tricky. They change so much, it's hard to really nail down a good one that's consistent. But recently, I'm trying to think, the number one shoe, if I had to pick one for you, would be the Fresh Foam More shoe by New Balance. Fresh Foam More. They've kind of been tinkering with it lately, but one of their versions of that shoe was the stiffest, strongest thing I've ever felt, with a lot of cushion. So it's a good shoe to try. Shoes are critical. The next step is an orthotic. An orthotic is a simple device. Usually it's hard plastic. You can cover this with as much cushion as you want, but the orthotic itself needs to be strong. If it doesn't hold the arch up and strengthen it or support the weight of the arch, you're not going to accomplish very much. I see a lot of cheap Dr. Scholl's type orthotics. They don't do much for the foot except for pad the thing, and that's okay if that's what you're looking for is padding, but if we're trying to support the arch, take away the stress throughout the plantar fascia, you need a stronger orthotic. The cheapest over-the-counter, highest quality one I've found is Power Step. This is a Power Step. They have different models. The one you're looking for is the ProTech Control. It's got a little blue dot at the heel, a little extra padding. The reason this one's so great is it's got what's called a post. It's a squared off bit of material on the heel. When you place that in a shoe, it keeps it from rocking. It stabilizes the foot. This one's great. It holds up pretty well. It's fairly strong, and it's got a nice layer of padding. If I had to hand pick an over-the-counter one, I'd go for the Power Step. Super feet are pretty good. Beyond that, I'd have to see, but those are some of my favorites. The problem with these is you can't modify them very well. So if you have an arch shape that's very odd, really flat foot or a high arch, these aren't going to fit you very well, and they may not be comfortable. Good place to start. I often tell people, let's try these as a test run, see if you like the concept of pressure on the arch. If you can tolerate the pressure, great. These are only going to last 6 months to a year at most. If you're a heavy walker, if you're a little overweight and you do a lot of walking, these aren't going to last very long. But if they work well and you feel like your pain responds well to it, then a custom orthotic is the next step. We use a polypropylene orthotic in my office. Again, this is just the bare shell of the orthotic. We often add a post to this. We often add padding. This version, however, is indestructible. I've seen these last 50 years they were made by Dr. Lowe, my predecessor, and they're amazing. They never wear out. We take a mold of these in a foam box. We take an impression of your foot. It should fit you like a glove. So when you're walking, there's no moment of impact, right? It's right with your foot. So even though they're hard, they're actually quite comfortable. I'm wearing some right now. They feel great. I forget they're even in my shoes. So they're not for everyone. Some people have really tender feet and they don't like the idea of a hard orthotic. But if we can get you comfortable in them, they last forever. This version I can get in anything, soccer cleats, golf shoes, you name it, even biking, road biking shoes, which are very narrow and small. I've even got these in ski boots, climbing shoes, you name it. We can make it work, and they work quite well. So orthotics, very important. Your best bet for long-term prevention of further attacks of the plantar fasciitis is a good shoe and an orthotic. I cannot overemphasize that enough. I have so many people come in and say, Doc, I was feeling great. It'd been a year or two since I'd had an episode until I went to Disneyland. We went to the beach, ran around for 3 days in bare feet, and now my pain's back. Classic story. Or they were doing great with shoes and orthotics, and now they're worn out. Now the shoes are super flexible. The orthotics has become super flexible, and it's not doing anything for them, and their pain comes back. So keep that in mind. The next stage of treatment is basic physical therapy. We're trying to get rid of the inflammation. We're trying to rest the foot as much as we can. So we're talking about icing every night, 20 minutes on, 20 minutes off, maybe another round of that. Ibuprofen, if you can take it, you have to watch out for your kidneys. 800 ibuprofen 3 times a day for a few weeks is a good way to get rid of the inflammation if you can. Again, you have to have good kidney function to be able to do that. You have to watch your stomach. Ulcers, bleeding ulcers can be a problem, so you have to be very careful. Again, always consult your doctor before doing any of this treatment. It's critical. Icing, ibuprofen is going to help get rid of the inflammation. Good old rest. Try to get off your feet as much as you can. If you have a job where you're standing all the time, try to get off your feet when you can. Maybe put some bar stools around your workspace and see if you can't rest and get your weight off your feet more often than not. Teachers, lecturers, you can do the same thing, but try to rest it. Massage is useful. Deep tissue massage. Physical therapists are great at this. They've got 2 different techniques, Astym and Grastym, where they take plastic instruments and really deep tissue massage the thing. That can be useful. Icing it, sometimes we'll get a frozen water bottle and roll it on the bottom of the foot, so you're massaging those tissues as well as icing at the same time. That can't hurt. The next least invasive thing would be a night splint. This looks like a medieval torture device because it kind of is. I can't imagine sleeping in one of these, but the science is pretty sound. Some good studies out there that show that if you can keep your foot at 90 degrees during the night, that plantar fascia, your foot doesn't relax and that plantar fascia doesn't stiffen up. So when you sleep at night, your foot relaxes, it stiffens up. When you take those first few steps in the morning, you're powerfully stretching those tissues and probably tearing them at the very micro level. That's why it hurts so much when you get out of bed, because you have to loosen things up. So stretch it before you get out of bed, warm it up, massage it, or wear a night splint. You keep your foot stretched at 90 degrees all night long. That process, that cycle never has a chance to happen, and you can avoid that first steps pain in the morning. So for people that have first early morning pain, night splint's a good way to go if you can sleep in it. I'm a big fan of the dorsal night splint. If this was your foot goes actually on this side of it like that. It actually fits inside this sleeve here. I like this a whole lot better than, say, the Strasbourg sock, which is a device that is a big sock with a strap that comes out near the toes. The problem with that is it pulls your toes back, and I have a lot of people complain about your foot going numb during the night. So not a big fan of that because it stretches out everything too much. So night splints are great. Moving into the next layer of more invasive treatments, steroid shots can be very useful. People always come in and they say, "Doc, I know I can't have very many of these," and that's true. You can only have so many in the same exact spot every year, or you're going to see the soft tissues thinning out and atrophying, and if that happens, you can't get it back. Plantar fascia could rupture, tendons nearby could rupture, and you have to be very careful. That being said, 1 or 2, maybe 3 shots a year at specific doses can be done safely, and I have had really good success with steroid shots in the plantar fascia, with a big caveat. If you are not doing everything right with good shoes, and good orthotics, the steroid shot is going to calm the inflammation down into your soft tissues, into the plantar fascia, and you're going to feel great. But if you're not protecting it mechanically, the pain's going to come back once the steroid wears off. So with the doses I use of Kenalog and dexamethasone, one is a longer acting, one's a shorter acting steroid, I can get 2 or 3 or 4 months of activity out of those steroids. If you do everything else right, icing, stretching, orthotics, night splints, and good shoes, that steroid shot may be enough to calm things down and give your body a window of opportunity where it might actually heal the plantar fascia. So I have plenty of people that come in, we do a shot, they do everything else right, and they're cured. It might take a few months for everything to calm down and go away, but they do very well. Sometimes I'll piggyback a second shot on top of the first shot, maybe 3 or 4 weeks later. If they come back in and they say, "Look, I am 70% better, but I'm kind of stuck and maybe it's starting to feel a lot worse," I'll do a second shot right then. That sometimes will piggyback off the first shot, calm down the remaining inflammation and get rid of their pain. That's been pretty successful. You get into the third, fourth shot, you're asking for trouble. You might lose the fat pad to atrophying on the bottom of the foot. You might rupture a plantar fascia, so you have to be very careful with that. Not a super big fan of that. So That's my first visit approach. If we can get through that, I would say 80-90% of people are doing great. They're doing fine. We don't need to talk about anything more invasive. We may repeat that a couple of times. They may be back in 6 months when we do it again, but eventually they get better. One study showed that the average plantar fascial patient deals with this for 9 months or more before it goes away, so be patient. It takes a long time. The next most invasive treatment would be amniotic injections or stem cell therapy or PRP. I kind of lump all those together just because they're kind of similar. This is AmnioFix by Mimetics. It's an injectable amniotic membrane product. Similar in effect to PRP, where they dry your blood out, spin it down to just the concentrated platelets, and it re-inject it into your body. There's a number of other products out there on the market that kind of boil down to the same thing, where they're trying to stimulate healing, they're trying to knock out the inflammation without the negative side effects of atrophying and weakening of tissues like steroid. The drawback with this approach, both PRP and the amniotic injections, is that it hurts like a bugger for a couple of weeks. And because it's working through the natural healing processes of your body, you can't take ibuprofen or anything that would stop the inflammatory state of your body. So you can't combine it with steroid shots or oral steroids or ibuprofen. So you're kind of stuck icing it, taking Tylenol, which doesn't work very well, or a narcotic if your doctor's that brave of a doctor. It can hurt for a while and it takes a lot longer to work, but they have very few side effects other than that initial pain. If you can get the doctor to do a good injection right in the right place, and you're patient and you can go through those week or 2 or 3 with pain, sometimes that'll cure people. Why not try it before you start talking more invasive surgery? I think it's something that should be done. Why not? It's an option. Insurance companies aren't paying for those anymore, or in the case of the amniotic injections, they're not quite paying for them yet, but it's coming. They said they were approved and they're not. It's in the works. Okay, the next stage of treatment, we started to get more invasive. We're talking about dry needling. There's another process called 10X or Topaz. All of these boil down to the same concept, in that we take a percutaneous approach with a needle or a probe, and where the plantar fascia is thickened, where it's inflamed, we go in either through one hole or a grid of holes, poke a bunch of holes in the plantar fascia, and try to create a micro injury. We're trying to tell the body, enough with a chronic inflammatory process, let's change this into an acute injury, change the story, and see if the body will just finally heal the thing. Astym and Grastym with physical therapy, I think, acts along the same pathway, where it's a deep, really strong, deep tissue massage, same kind of concept. If you can interrupt the chronic cycle of inflammation, the pain might go away and the body might heal it up. There are success stories for sure. You don't burn a lot of bridges with that. It doesn't create a lot of scar tissue. As long as the doctor knows what they're doing and they're staying away from nerves and that, it's not a bad idea. It may or may not be a trip to the O.R. because of the pain of doing that. Sometimes we can do a local block in the office, block the nerves that give you feeling to the heel, do the procedure, and people do quite well with some post-operative pain medication. So that's an option for sure. The end-all be-all surgery here is the plantar fascial release. Keep in mind that plantar fascia is extremely tight band of tissue. Sometimes it's the tension that's the problem. If you have a really high arch, a really aggressive high arch, that plantar fascia is often so tight that it just doesn't have a prayer of healing because of the tension. So surgically, we'll come in from the side of the foot, make a very small incision. You can either do this with endoscopic tools, which help us see through a camera, or you can do it with small instrumentation. Doesn't really matter as long as you release the plantar fascia. And what we're doing is cutting through about 50% of the width of that plantar fascia. If we can get those tissues to open up and release the tension on that plantar fascia, it can be extremely helpful for healing, in hopes that it'll heal in a lengthened position. After surgery, we're putting people in a cam boot, and the idea there is we want to keep that foot at 90 degrees so it doesn't shorten up and we lose the correction we've had. Recovery is pretty quick. You're 2 or 3 weeks before stitches come out, and then you're looking for that pain to go away. The problem with this surgery is you are walking right on the surgery site, right? We've just cut right through that plantar fascia. Now you're pounding it when you walk. That can delay healing for a while. So I tell people you might be a couple of months before you're out there walking, 3 or 4 months before you're running or more. The cop-out answer is going to be 6 months. It seems like forever, but it's because we've just cut through the plantar fascia. You're going to walk right on it, and that's going to take a while to heal. The interesting thing with treatments of plantar fasciitis is, the temptation is why don't we just put you in a big boot, put you in crutches, hardly use it, and just rest it. That does work. People feel great when you do that. However, as soon as you start using it again, the pain tends to come back. You have to heal the plantar fascia when you're being somewhat active. That means probably cutting out running and jogging. But if you're walking a little bit, you're using it, and you're keeping it loose, it tends to heal better and for a much longer period than if we totally immobilize it and protect it too much. So that's an interesting thing about the plantar fascia is you need to heal it in a somewhat active state. There are a number of treatments for plantar fasciitis because it's such a common problem. Some of it's more fringe. You may hear about shockwave therapy. With shockwave therapy, a device delivers a high impact amount of energy. It's very similar to dry needling and those other micro trauma approaches where we're just trying to create an acute injury, get the body's attention to have it switch gears from chronic to acute healing process. Sometimes that can be useful. Insurance used to pay for it. It doesn't seem like they pay for it anymore. But there are doctors out there offering it, and there are success stories. So I have nothing against that as far as trying it. It doesn't seem to burn any bridges. The science is kind of so-so depending on what studies you read, but that is definitely an option. The bigger surgery with the plantar fascial release is when there's a big heel spur and we're convinced that spur is part of the problem. If the spur is huge, if it's broken, if it looks abnormal, sometimes we have to make a bigger incision on the side of the heel, go in, take off the bone spur, and release the plantar fascia at the same time. One of the really tricky problems with plantar fasciitis is there's a disease state called tarsal tunnel syndrome. I'm sure you've heard of carpal tunnel syndrome in the hands. Same exact idea. There's a nerve that comes down through the tarsal tunnel and then splits into a branch, into a Y, and then the branches get out into the toes. On its way through the medial side of the ankle here, it can get trapped in a very tight fascial band. The flexor retinaculum is this tight band of tissue. It's the roof of the tarsal tunnel. And sometimes it puts so much pressure on the nerve that you get burning, tingling, numbness, type pain, radiating pain on the bottom of your foot. What's so tricky about this is that one small branch of that tarsal tunnel, the posterior tibial nerve, is that small branch comes down and gives you feeling to the heel bone, right where the plantar fascia attaches. So it's possible to have pain in the plantar fascia because there's a pinched nerve farther up. And that's when things get tricky. And so you can have people, I can't tell you how many times I've had patients come see me. The previous doctor was convinced it was plantar fasciitis and they did 1 million injections, tried everything, nothing worked. We push along the tarsal tunnel and sure enough, you put enough pressure on the right spot of that nerve and the heel lights up. Turns out it was tarsal tunnel the whole time. Or when things get really tricky, it's when they had plantar fasciitis, they start walking funny, trying to avoid that pain. That puts a lot of pressure on the tarsal tunnel, and now they've got tarsal tunnel syndrome and plantar fasciitis. That's a hard one to let your doctors sort out. But if you have burning, tingling numbness on the bottom of your foot, if you can push along the posterior tibial nerve, which is right on the medial side of your ankle, and it recreates the symptoms of heel pain you've had along the bottom of your foot or in the heel, you probably need to investigate tarsal tunnel, and that's a whole other discussion we'll get into another day. But that's one that tricks doctors all the time. It tricked me for a long time before I started keying into it in my practice. Something to keep in mind. Plantar fasciitis, it's not easy. It's a hard one. It's a very complicated diagnosis because of how hard it is to cure, not so much how hard it is to make the diagnosis in most cases. So be patient, give your doctor many chances to get that thing healed up, and know that it can take months, if not years, to cure. And may the force be with you, because it's a hard one to fix sometimes. I will say this: when you start having heel pain, and it fits the story of plantar fasciitis with the first steps pain in the morning and so on, the sooner you get to a doctor, the faster it's going to go away. If people come in and it's only been a few weeks to a few months of pain, and we do all the things we've talked about with a steroid shot, orthotics of some kind, a good shoe, a stretching routine, an icing routine, and so on, we modify their life a little bit for the near future, we have really good success. When it's been 5 years, 10 years, and they've just been plowing through the pain, tissues are now damaged in there, and it becomes really hard to treat. So get to your doctor as fast as you can. If you don't like what they're saying, get a second opinion, but keep working on it until you get somewhere with a good professional. Please remember that we are doing these lectures for Operation Underground Railroad. These guys are an amazing group of people that go around the world freeing children from sex trafficking situations. There are rings of people, groups of people who take children, they farm them out for prostitution. It's a horrible thing that happens out there, but it's very real. Look up O.U.R. Rescue, OURrescue.org. Tim Ballard started this group. They do amazing work. I think to date they've saved 4,000 children from these horrible situations. They provide aftercare, placement, adoption, whatever it takes to get them in better situations. We are doing these lectures to raise money for them. So if you can, make a donation at OURrescue.org. Your donation can make a huge difference. That's why we're doing this. So keep that in mind and have a great day.